Hello, good evening, friends. Today we'll discuss a very that is your linagliptin. So we'll discuss the linagliptin in renal impaired patients. So this is the data which is taken from the National Health and Nutritional Examination Survey, the Haynes 4 survey. It says that CKD prevalence is much more greater with diabetes when it is compared with in the patients without diabetes. So CKD prevalence is much more greater in diabetes when compared with non-diabetes. It is about 40.2% when compared with non-diabetes, that is 15.4%. Now this is about the prevalence of CKD in diabetes. Now I will briefly tell about the staging of the CKD. If the patient have eGFR more than 90 and patient has albuminuria, this is stage 1 CKD. And if the patient has eGFR more than 90 but there is no albuminuria, then it is not a CKD, it is normal. Then if the eGFR is between 60 to 89, it is stage 2 CKD, and if the eGFR is between 30 to 59, it is stage 3 CKD, and if the eGFR is between 15 to 29, it is stage 4 CKD, and if the eGFR is less than 15, it is stage 5 CKD. So out of all the stages of the CKD, the stage which is more prevalent is stage 3. This is the stage 3 CKD. It is much more prevalent among other stages of the CKD. So this was about the prevalence of CKD in diabetes. Now this is about the prevalence of cardiovascular risk factors in type 2 diabetes. So this is the prevalence. So arterial hypertension accounts for 67% prevalent in diabetes. Then poor glycemic control, it is 63% prevalent in diabetes. Then microalbuminuria, it is 30% prevalent in diabetic. Then dyslipidemia, it is prevalent in 20% of diabetics. So this is about the prevalence of cardiovascular risk factors in type 2 diabetes. Out of all, majority is found by the arterial hypertension, which is 67% prevalent. Now this is the omnious octet of hyperglycemia. There are 8 factors that contribute to hyperglycemia in type 2 diabetes. The various factors which are involved, we have the beta cells, then fat, then muscle, liver, gut, alpha cell, kidney and brain. So there are 8 factors that contribute to the hyperglycemia. As we can see here, there is decreased insulin secretion by the beta cell of the pancreas that contributes to hyperglycemia. Then similarly, increased glucagon production by the alpha cell of the pancreas. Then increased hepatic gluconeogenesis contributes to hyperglycemia. Similarly, neurotransmitter dysfunction, decreased glucose uptake by the muscle cells, increased glucose absorption from the kidneys, increased lipolysis and decreased incretin effect. All these factors contribute to hyperglycemia. This is the omnious octet that is responsible for causing the hyperglycemia in type 2 diabetics. Now this is the mode of action of the GLP-1. The GLP-1 often after ingestion of the food, as food goes into the gut, it causes the release of GLP-1 from the L cells present in the jejunum and ileum. So as the food goes down, it stimulates the L cells in the jejunum and ileum to cause the release of GLP-1. Then GLP-1 acts on gut to slow the gastric emptying. Then it acts on the brain to reduce the food intake. Then similarly it acts on the pancreas to stimulate the insulin secretion and suppresses the glucagon secretion from the pancreas, and all these factors will contribute in further lowering of the blood sugar. So as we take the food goes into the gut and it causes the release of GLP. Then GLP acts on various organ system to reduce the blood sugar. Now this is the long-term effects demonstrated by the GLP. GLP increases the beta cell mass and it also maintains the beta cell efficiency. Then this is the incretin effect in type 2 diabetes is reduced. Before we understand why it is reduced, I would like to tell you what is incretin effect. Here we are giving the IV glucose and here we are giving the oral glucose. It has been seen that With IV glucose there is release of insulin, and with oral glucose there is also release of insulin. But with oral glucose the release of insulin is way high. It's very augmented response of insulin secretion with oral glucose. This is due to the fact as we consume the oral glucose, it goes to the gut, causes the release of GLP. Then GLP acts on the various organ system as we already discussed, and GLP-1 also acts on the pancreas to cause the insulin secretion. So this is incretin effect in normal subject. It is normal, but in diabetes it is reduced. This is due to the fact as we consume the food, it causes the release of incretin, but incretin acts on the pancreas. But in diabetes the beta cell number is reduced, so there is not much release of insulin. So that's why the insulin if incretin effect is reduced in diabetes. Now this is how the GLP-1 is secreted and inactivated. As we already discussed, GLP is secreted by the L cells from the jejunum and the ileum. Then it is in active form. This active form of GLP is converted into inactive form by the enzyme, that is the DPP4. This DPP4 convert the active GLP to inactive form. Now the here our drug acts, that is the linagliptin. Linagliptin inhibit these enzymes, that these enzymes will not work. Then GLP active form, this is the active form, will not be able to convert into inactive form. So the active form of GLP-1 rises in the blood, and this GLP-1 then acts on various organ systems as we already discussed to cause the lowering of the blood glucose. So in this way linagliptin works, that is it inhibits the enzyme DPP4 to increase the level of GLP-1, which acts on organ system to reduce the blood sugar. Now what are the goals in diabetics? What are the treatment goals? First we have to reduce the HbA1c, we have to reduce the weight, then we have to control their lipid profile, LDL, high density lipoprotein and triglycerides. Now this is another bar chart which shows that with the declining in the renal function there is increased risk of hypoglycemia. As we can see here that if the patient has a CKD, that is his renal function are declining, and he also has diabetes, with increased risk of with decline in renal function there is increased risk of hypoglycemia, as we can see here. Now this is about the linagliptin. Linagliptin is the only DPP4 inhibitor that does not require any dose adjustment in renal failure. As we can see, linagliptin can be given in at mild renal impairment, at moderate renal impairment, at severe renal impairment, even at risk of renal impairment, and even if the patient has no renal issue, linagliptin can be safely given. I would like to tell you here that mild renal impairment is when the eGFR is between 50 to 80. Moderate is when the eGFR is between 30 to 50, and less than 30 is severe. Less than 30 EGF is severe renal impairment. So linagliptin can be given in mild, moderate and severe renal impairment as a full dose of 5 mg OD dose. While sitagliptin we can give 100 mg, that is full dose 100 mg OD up to mild renal impairment. Then in moderate renal impairment we have to reduce the dose. We have to give at a dose of 50 mg OD. Then in severe renal impairment we will give at a dose of 25 mg OD. Now about the vildagliptin, which comes in the trade name of Galvas, we can give 50 mg BD up to mild renal impairment, 50 mg BD dose. But in moderate to severe renal impairment, we have to give at a dose of 50 mg OD dose, 50 mg once daily dosing for vildagliptin. Now similarly, saxagliptin we can give at a dose of 5 mg up to mild renal impairment, and in a case of moderate to severe renal impairment we have to reduce the dose, that is 2.5 mg OD dose. So linagliptin has no renal issue. It can be given in whether mild, moderate or severe renal impairment at a dose of 5 mg. Now this is about briefly about the overview of the linagliptin. Linagliptin has a very good efficacy. It has a durable efficacy which lasts up to 2 years. Now about the safety and tolerability, it does not cause much relevant weight gain. There is very low risk of hypoglycemia. The most common adverse effect which is noted with the linagliptin is nasopharyngitis, and it is also not associated with increase in cardiovascular risk. It is primarily excreted by bile and gut. About 95% excretion occurs by bile and gut, and remaining 5% excretion occurs by kidneys. So no dose adjustment is required in whether renal or hepatic impairment. Now, this is about the long lasting effect of inhibition on the DPP4 by the linagliptin. Suppose if the patient has taken linagliptin today, and we will see after even after 24 hours, that is even after 1 day, it keeps the enzyme inhibited by more than 80%. By more than 80% approximately, the enzymes remain inhibited. Linagliptin keeps the enzyme inhibited even after 24 hours by more than 80%. So it has a long lasting effect on inhibiting the DPP4 enzyme. Now, as we consume the linagliptin, it has been seen that if a patient has consumed the linagliptin, in his blood we will find their GLP-1 keeps on increasing. As we can see in this diagram, after 1 month of consuming the linagliptin, its GLP-1 level rises from 4.4 to 13.9 picomole per liter. So there is approximately 3.42 fold increase in the GLP level in a patient who is taking the linagliptin. So linagliptin increases the GLP levels in the patients. Now this is also very important slide. Here we can see if the patient is taking the linagliptin, we can see there is very less risk of apoptosis. So linagliptin causes less apoptosis of the beta cells. So it has been seen that on studying the beta cells of the patients who are taking the linagliptin, it has been seen that linagliptin causes less apoptosis. So this indirect provides the evidence of protective effect of linagliptin on beta cell survival and insulin secretion. Now, this is about the comparison of the efficacy between linagliptin and glimepiride, and it has been seen that when patient has taken linagliptin and glimepiride for a period of 2 years, it has been seen that they both cause HbA1c reduction by 0.6. So linagliptin and glimepiride has almost similar efficacy in reducing the HbA1c. Now, Now, this is another important slide. It has been seen that in clinical trials in healthy subjects, it has been seen that single dose of linagliptin up to 600 mg can be given without any adverse drug reaction. So 600 mg of linagliptin can be given without any adverse drug reaction, but the therapeutic dose is only 5 mg. So the maximum tolerated dose of linagliptin is 600 mg, but the therapeutic dose is 5 mg. Now this is slide showing the adverse effect. We can see pancreatitis with linagliptin, we can see headache, upper respiratory tract infections, nasopharyngitis most common, that cough. Then it can increase the hepatic enzyme. Serum creatinine increases only 0% when compared with placebo, which is 0.1%. So it is very much safe in kidney patients. It can also cause urinary tract infection, blood and lymphatic system disorders, and hypersensitivity reactions can occur with linagliptin. Now this is the comparison between the linagliptin and the glimepiride in terms of hypoglycemia, and we can see where there is very less risk of hypoglycemia with linagliptin when compared with glimepiride. Glimepiride causes way much higher risk of hypoglycemia when compared with linagliptin. Then in terms of weight reduction, linagliptin causes relative weight loss when compared with glimepiride. There is relative weight loss when compared with glimepiride. And this slide is showing the efficacy wise, whether both linagliptin and glimepiride are almost similar, having similar efficacy. Now this is how the linagliptin is absorbed. We will take 5 mg dose, and it can be taken with or without food, and the bioavailability is 30%, and it is 95% bound to the plasma proteins. After absorption, it goes to the liver where 90% remains unchanged and remaining 10% convert into inactive metabolite. After that, about 95%, as already discussed, is excreted by the bile and the gut, and remaining 5% of the linagliptin is excreted by the kidneys. So this is about the pharmacokinetics of the linagliptin. Now this we can see all the DPP-4 inhibitor like sitagliptin, vildagliptin and saxagliptin, they are excreted primarily by the kidneys. Except the linagliptin, in linagliptin only 5% excretion occurs by kidney, remaining 95% occurs by bile or gut. So it is pretty safe in renal patients. The linagliptin require no dose adjustment in kidney patients. Now this slide shows that if a patient has taken linagliptin for 6 months, it has been seen that their GFR remains unchanged. As we can see here that if the eGFR before consuming the linagliptin is 120 and after taking the linagliptin it remains almost same, that is 119 in a patient with normal renal function. Similarly, for mild, moderate and severe renal impairment, the eGFR remains almost unchanged. So it is pretty safe in kidney patient. It does not cause much change in the eGFR values. Now this is the slide which shows the characteristics of the linagliptin. Linagliptin is one dose fits in all. There is no dose adjustment in renal impairment, hepatic impairment, no dose adjustment based on the drug-drug interaction, no monitoring of the renal function, no skin toxicity, no liver toxicity, no reports of decrease in renal function is noted with the use of linagliptin when compared with other DPP-4 inhibitors. Now this slide shows the incident rate of cardiovascular events. Here the patient has taken the linagliptin and here the comparative group where the patient has taken glimepiride and voglibose. We can pretty well see here the incident rate with linagliptin is 0.3% of cardiovascular event out of approximately 3300 patients, as compared with comparator group, that is the patient taking glimepiride and voglibose, the incident is 1.2% approximately out of 2000 patients. So the linagliptin, the cardiovascular incident is way much smaller as compared with the comparator group. So linagliptin is not associated with increased cardiovascular risk. So this slide is also important. Now this was the trial which was carried out in approximately 7000 patients in 1:1 ratio randomized trial. In one arm they were given the linagliptin and in another arm they were given the placebo. And the outcome of that trial is that linagliptin demonstrated a long-term cardiovascular safety profile in patients with type 2 diabetes, including those with cardiovascular disease and kidney disease. About the hospitalization, linagliptin showed no increase in risk of hospitalization for heart failure, even in patients at high risk of heart failure. Now this is the overview of the linagliptin. Linagliptin can be given in hepatic impairment, can be given in patients with decreased renal functions, with cardiovascular disease, whether the patient is obese or lean, we can use pretty well the linagliptin. It can be used if the patient has long disease duration, even out of ethnicity. It can be given in all age group including old age because there is less risk of hypoglycemia. So this was about the linagliptin. Thank you.